I'd next like to invite Dr. Michelle Alonso Basanti. She is the Vice Chair for the Clinical Division of our Radiation Oncology Department here at Penn Medicine. And she's really organized three really interesting cases tonight. They're going to highlight and put this information together. Michelle, thank you so much for joining us.
Thank you so much, Lynn. Thank you for the introduction. I'm going to introduce our great panel of faculty that have come together, and thank you for staying with us for this last session, which I always like to be the most interesting to talk about real cases. I want to obviously bring back Dr. Agarwal, who will be joining us on this panel. Dr. Major Kenneth Lee, who is an assistant professor in gastrointestinal surgery. Dr. Selena Luger, who is professor of medicine and hematology oncology. Dr. Anna Kolansky, who is an associate professor in the Department of Radiology. And Dr. Alexander Wang, who's an assistant professor in the Department of Medicine and Hematology Oncology. So with that being said, I'm jumping right into sharing my screen and sharing our cases, primarily because we have a lot to go through with a lot of different questions. So having said that, we have a 55-year-old Spanish-speaking female originally from Mexico diagnosed with AML in March 13th, 2020, appropriate date, and on presentation with cytopenias and circulating blasts. The decision was made to start treatment with azacitidine and venetoclax, and a regimen traditionally used for patients over 75 with comorbidities, but unlike standard therapy, does not require a 4 to 6 week hospital stay. So Selena, can you tell us a little bit of the understanding of what came to this decision for you and the team?
Sure, thank you. So the patient was diagnosed with what we consider a curable disease, and standard therapy would typically involve aggressive therapy, as you said, with a 4 to 6 week hospitalization. But in March, we were really worried about the risk of hospitalization, and both the disease and its treatment increased the risk of infection. So we rapidly got involved in committees with national and international colleagues, as Larry mentioned, including colleagues from China, Italy, and Spain, to create guidelines for how to best treat our diseases. And we chose to use a regimen that could be used in the outpatient setting for patients with comorbidities, essentially considering COVID the comorbidity, knowing that it would still require outpatient nursing support and frequent clinic visits, but decreasing the need for hospitalization and the risk of infection and a potential ICU stay.
Great. So Amaro's done after the first cycle, demonstrates no evidence of residual leukemia, but with persistent necrosis. So a second cycle, outpatient, with while a donor search is initiated, with the ultimate goal to go to allogenic transplant. In May, June, a decision is made to give high-dose cytarabine, requiring a 5-day hospitalization and aggressive outpatient transfusion support in the clinic several days a week. What made you feel comfortable, Selena, to kind of start that process and start a hospitalization for this patient?
So as you heard from Lynn, from between March and May, we learned quite a bit about hospital treatment and safety for both our patients and our staff. And as we were one of the few services still treating non-COVID patients throughout the pandemic regularly in the hospital, we had a working group really involving multidisciplinary clinicians, administrators, lab medicine coordinators to try and develop best practices. And while, as Charu mentioned, we transitioned much of our care to the outpatient or home setting, when we felt it to be the best treatment, we needed to proceed with inpatient treatment. So in addition to limiting the visitors and social distancing, what we did was we screened all patients being admitted, as Lynn mentioned. We did COVID testing within 72 hours of admission. And in some patients, we also did a second test at admission, which is what we did with our leukemia patients. And some we did screening chest CTs as well.
Perfect. And so team obviously created these processes. COVID testing was done prior to each admission. And we did, as you discussed, 1 to 2 testing versus even the value of baseline CT as a screening tool. We move on. She does get screened prior to each admission and is negative both in May and June. She recovers nicely after her consolidation therapy, and a donor is identified in July. So she proceeds with pre-transplant evaluation and plan for admission for transplant in August. Tell us a little bit about that planning for all these tests prior to transplant, including the planning of a marrow biopsy in July with interventional radiology, who, as we've seen before, was doing pre-procedure testing, where now in July you get a call where she's COVID positive.
So it was actually somewhat fortuitous because we normally do these biopsies in the office, and she didn't want it done in the office, so we scheduled it in IR. So we did a test and found out she was positive, and she had been negative, as you saw, several times beforehand. But she lives with extended family, as is not surprising, some of whom are not able to social distance. So although she thought she was being safe by not going out, she really was at increased risk for COVID. So now we had to contact trace all of those who had been involved in her care, both in her office and in her home, figuring out who needed to be quarantined. And now we had to delay all of the testing, even though she was asymptomatic, and figure out when it would be safe to resume her testing. As Lynn mentioned, this was right at the time that our policy changed from being time-based to being time-based instead of requiring negative tests. So that helped us a little bit in terms of what we were going to do next.
So we see that in August, she's able to complete all her pre-transplant evaluation and get some dental work done, her tooth extracted. And in September, you actually admitted her for transplant. Tell us a little bit of how that has gone.
So as you might imagine, since March, we've been very cautious with our decision to proceed with allogeneic transplant in our patients. They need to be hospitalized. We have to immunosuppress them. Their diseases and their treatment was immunosuppressive. We don't know how that's going to interact with COVID. We don't really understand that. Yet we feel we need to continue to do transplants when appropriate and do our best to hold Scylla, the six-headed monster that Charu mentioned, away. So we've done a lot of things as a team. Our transplant floor has its own air supply and HEPA filtration, so that made it somewhat safer to admit these patients. And we've had a massive team effort to assess and adjust the logistics. So we do things like with new workflows. For example, we now collect and freeze donor cells prior to admission. We've now done many of our outpatient evaluations as possible pre-transplant as well as post-transplant. And we constantly reassess and adjust our processes with our team. So fortunately, that's allowed us to maintain a busy census similar to what it was prior to the COVID era. And now we just still don't understand how we'll have to deal with immunosuppression, but we've really been able to proceed with this massive team effort to successfully transplant all the patients we need to transplant.
That's great. Thank you, Selena. Shows the evolution of a case really through these last 6-7 months. So I appreciate it. We're going to move on to our second case. This is a 66-year-old male with stage 3B non-small cell lung carcinoma diagnosed in April 2020. And as a team, what we tried to do overall, as we was discussed, we still continue to meet virtually via multidisciplinary tumor boards. We decided we want to go ahead and continue doing planned care, which is concurrent chemoradiation. So one of the questions obviously is in radiation was, what are your considerations, any special considerations that we had in radiation? And we did look at a number of things that we did in the department. Our goal, as was all our goals, was to continue our patients that did not have COVID onto the pathway to get their curative cancer care. We definitely instituted PPE protocols very early on. These are patients that come every day for treatment, Monday through Friday. So it's a constant visit to the hospital that is needed. There's no other way to do it. Our team and staff, therapists and nurses in particular, were always in consideration of having to manage, per machine, 20 to 30 patients every single day. And those practices really did impact us. In regards to the patient's treatment, we usually use motion management devices to keep, obviously, lungs from moving so we can target. And we made a very conscious effort to think about which motion devices we were using. Anything that was really using deep inspiration or respiratory inspiration, we really held at the beginning with a slow evolution with our infectious prevention colleagues to figure out what was going to be safe or not. But we could use abdominal compression, and that's what we considered in a lot of our lung cancer patients. We were only testing at the beginning for symptoms, as with most cases, but did start treating and have been testing prior to each planning session or simulation. Initially went through a rule of doing simulation and treatment. And again, as it has been found, and we've learned so much, and as Larry has shown us, that we've kind of evolved in that regard so that we're prepared should a patient be positive before treatment. Charu, in regards to medical oncology and to chemotherapy, what were you thinking about in our definitive patients during this time?
So Michelle, in addition to what you mentioned, most of our patients were being discussed in a multidisciplinary tumor board setting. Our intent for our definitively treated patients was always to deliver seamless care as safely as we could, with the key principle of risk mitigation in mind. For our patients with stage 3B non-small cell lung cancer, we did follow our paradigm of continuing with concurrent chemoradiation when we thought we could safely administer it. We incorporated telemedicine visits very early on into our practice, so that even if these patients were getting weekly chemotherapies, we could potentially see them remotely and minimize that interaction and potential of exposure. We were trying to minimize our myelosuppressive regimens and maximize our ability to treat with weekly regimens. We had also put out guidance early in the pandemic about perhaps using sequential chemoradiation for some patients. But I'm happy to say that most of our patients that we successfully took on during the pandemic did complete their chemoradiation therapy on time successfully.
And so in this case, this is what the CT scan looked like at the start of radiation. And our patients very typically have imaging done on the actual treatment machine in the treatment position. Typically, it's what we consider KV imaging or regular X-ray imaging, but once a week we were getting, and for most of our machines, we can actually get what we call a cone beam CT on the machine in the treatment position. And so this is what he looked like, what he was looking like at start. And as the doctor that day, we noticed that at his 10th fraction or 10th treatment, a cone beam fortuitously was needed to be done. And so obviously the picture changed quite a bit during this period of time. There was concern that this was early radiation change. And so we actually looked at the plan. And so that could not explain all the changes that we were actually seeing in the patient. We actually obtained a diagnostic CT scan. Anna, as you look at this, what are the thoughts that you in radiology were looking at, given the number of CT scans we were ordering during that period of time for situations such as this?
So we were really learning on the go here with the findings in COVID. And this case really illustrates the challenges in making the radiographic diagnosis of COVID-19 associated pneumonia in patients that are undergoing radiation or chemotherapy or immunotherapy. We see in this case, this patient develops ground glass opacities that are bilateral, that are diffuse, associated with consolidation in the right lung. And some of this could represent radiation pneumonitis, radiation associated organizing pneumonia, but there is a lot of disease in the contralateral lung. And so we have to think about, is this COVID-19 pneumonia? Is this another infection? Is he undergoing chemotherapy? And is this drug-related pneumonitis? And there really is a lot of overlap between these diseases, including other infections.
Thank you. So in this case, ironically, that was also we were seeing our patients. We continued to see our patients weekly, as we do when they're undergoing radiation. Of course, with precautions, our nurses were calling our patients the day before and even the day of, so that our time in the rooms were very much minimized. And ironically, he didn't have many symptoms at all. However, that changed very quickly as we ordered this diagnostic CT scan. The next day, he started to actually have symptoms and needed to actually have admission. COVID test was negative at the first try. COVID tested 48 hours later, again negative. And again, he continued to progress clinically with COVID symptoms and actually tested positive 2 days later. At this point, obviously, treatment had been held because it wasn't safe for him to come down to our department for treatment, given his requirements and his admission in the ICU. Charu, as we start to think about what we did for patients that were actually COVID positive, your thoughts from an oncology perspective?
So Michelle, this was right around the time when we were beginning to see national and international data emerge on the correlation of chemotherapy and worse outcomes, especially in patients with lung cancer. We very quickly adopted some of those practices. So if our patients had a COVID test that was positive, we hesitated to continue with their chemotherapy. And really, this was also the time when we were going from testing patients to resume chemotherapy to now going to a time-based resumption of treatment. At that point, I would safely say that we were just not comfortable continuing chemotherapy, and we held chemotherapy both during the phase that this patient was getting worked up, as well as, of course, when we got the COVID test positive.
From a radiation standpoint, obviously, as I discussed before, we did have multidisciplinary discussions and with our colleagues, particularly in our concurrent chemotherapy patients. I will venture to say that in our patients that were not getting chemotherapy, that it was radiation alone, similar to what's been shown, if they had minimal symptoms, we did have a committee formed that would look at each one of these cases that tested positive, let's say throughout, during the course of treatment, and made a decision with the treating physician as well as with input from our infectious disease colleagues to decide whether these patients needed to be treated or could be treated safely. And we actually did have very early on what we called our COVID positive protocol for these patients so that they could continue their curative intent. Obviously, this is all taking into account how symptomatic these patients were. Charu, can you comment a little bit on the role of palliative care during this period of time that we discussed so much?
Yeah, absolutely. So I think goals of care conversations have been critical during this pandemic, as Dr. Schuchter also pointed out in her talk, that we have had to discuss risk-benefit ratios very aggressively with our patients. We've employed supportive care for our patients, and also had some really tough discussions, even on our patients who were undergoing, unfortunately, definitive treatments.
And Alex, as I'm bringing you in to piggyback a little bit on John's talk as well, can you tell us a little bit about the immune fingerprint in this population and the severity? How symptomatic did it matter?
Yeah, so initially we're really concerned about whether our patients with checkpoint blockade would have increased hospitalizations or increased disease severity. And thankfully, we weren't really seeing that here at Penn. But we do know that cancer therapies, including checkpoint blockade and even radiation, have a significant impact on the human immune system. And so as John Weary had described, we can identify an immune signature or immune fingerprint of COVID-19, and in particular in severe COVID-19. And really this leads to a lot of questions in oncology. In that, what is the impact of different types of cancers on this immune fingerprint? For example, you can envision that patients with multiple myeloma or lymphoma would have a very different immune signature than other solid cancers, because of the nature of their disease. What is the impact of cancer treatments, for example, checkpoint blockade or B-cell directed therapies? But ultimately, the goal is, can we use this immune fingerprint to predict protective immunity in terms of effective antibody production? Or can we use it to identify immunologic vulnerabilities in our cancer population? And finally, the ultimate goal is to use this information to improve our vaccination strategies.
Thank you, Alex. And we'll move on to our third case. A 73-year-old male who was previously healthy presents with weight loss. The CT scan shows a sigmoid colon cancer near the rectosigmoid junction with a presumed metastatic liver mass. Kenneth, tell us a little bit about how you would have managed this patient in a pre-COVID era.
So this is a something that we deal with quite commonly, just because a fair percentage of patients, 25% or so, who have colon tumors present with liver metastases at the time. He has a favorable pattern of disease as these go. This is a distal sigmoid tumor with one liver metastasis. In the picture, there are a few other liver lesions, but those are all cysts. So there's one liver lesion and a distal sigmoid tumor. And the first thing to say is that we view this patient with curative intent. That is, our goal is to cure him in the end. These patients should all get multimodality care, meaning surgery plus chemotherapy. And so it becomes a matter of how you're going to sequence things. And there are a number of options that could be selected for this patient. The first breakpoint is whether to choose upfront neoadjuvant chemotherapy followed by resection, or whether to operate first and follow that with adjuvant chemotherapy. If you were to opt for a neoadjuvant strategy, then the next question becomes, how long will you go on with neoadjuvant chemotherapy before consideration of surgery? And then when you get to the end, or whether you opt for surgery first or neoadjuvant therapy first, from a surgery point of view, question that we deal with quite often is whether we're going to take these out at the same time, which would be a synchronous resection, the colon plus the liver, or whether we're going to stage the resections, for instance, do the liver first, followed by the colon, or even the colon followed by the liver. And the important thing is, I mean, especially in the pre-COVID era, is that you could do any of these things. They're all viable options, and you would be justified by data. So a lot of times the pattern of disease that the patient presents with nudges us a certain way, but for this particular patient with this pattern of disease, you really could choose any one of these options and be justified. So what we'll get into is sort of how the emphasis changed a little bit in the circumstance of COVID, and how that can nudge you one way or another.
So we are in a COVID era, right? So he gets diagnosed maybe at the end of March or early May, early April. What considerations were you thinking about?
So these are, without the actual granular specifics, these are the big picture, some of the big picture considerations that were important in the pandemic era. So first of all, everybody was mindful of the hospital census. That obviously includes the surgeons. We did not know how many beds we would have to dedicate to non-COVID patients, and the patients actually in a lot of circumstances were not that interested in being here. There was a second emphasis, which was avoiding procedures requiring the ICU. Obviously, at points in time, we had COVID dedicated ICUs. We did not know how many ICU beds we could dedicate to non-COVID patients. So we did not want to have patients at high risk for going to the ICU. As things evolved, especially in April, early May, there were significant restrictions on any case that could be deemed elective. This is a cancer case, but it is an elective case. This patient has other options, obviously. And then the overarching aspect of it all for both the providers and the patients is that, as to the extent that we did not want to make any compromises in cancer care. We wanted to provide the best care regardless of the presence of COVID, at least to the best of our abilities.
And so I'm going to continue here to say you decided as a team to go on to neoadjuvant chemotherapy, and you had mentioned what the duration of that neoadjuvant therapy was. This is, it could go on indefinitely, right, depending on the response. And so this patient goes on to 2 months of neoadjuvant therapy. Describe a little bit of what you noted on the follow-up PET scan. Yeah,
so this is the first thing to say is that the mandates, the restrictions on elective cases and the hospital census considerations would definitely shift this patient toward a neoadjuvant approach. It allows us to treat the patient. We're not making any compromises in his care, and he is out of the hospital. So now we're into the duration of therapy. Now, this patient, we're comparing apples and oranges, MRI and PET scan, but suffice it to say that he has either stable disease or a slight positive response to chemotherapy, meaning he's responding to therapy. Nothing's getting worse. He's 2 months in. In the non-COVID circumstances, we probably would consider operating at this point. I mean, he has demonstrated a response to therapy. He's gotten 2 months of chemotherapy. He has a surgical option, and we might proceed at this point. The COVID circumstance, of course, forces us to change our thinking a bit. He has stable disease. There's no reason that we cannot continue with chemotherapy if we're trying to delay his operation for a while. And so he actually got, instead of 2 months, he goes on and gets 4 months of chemotherapy and presents with an ongoing response at that point. So he gets 8 cycles, 4 months.
And then the decision for surgery is?
Synchronous resection versus stage resection. And, again, the circumstance of COVID kind of tilts the odds a bit in favor of synchronous resection. That's one operation. The hope is that we'll reduce his overall length of stay. He gets one procedure. We hope that we are decreasing the odds of readmission, one hospital stay as opposed to 2 procedures separated by a few weeks with, probably some chance for readmission for each one. And so in the viewed in totality, what we did here is take a patient with a lot of options and kind of tailor things in part to some of the constraints that we were facing in the COVID era. But everything we did was is by the books, and there's really no compromise in the way that he was treated.
Thank you.